Hi, welcome back to the Pediatric Sedation and Anesthesia course. My name is Gary Badger, Professor of Pediatric Dentistry at the UT Health School of Dentistry at Houston. We're welcoming you back to the continuation of this program. Today we're going to be discussing the pharmacology of sedation agents. As a disclosure, I receive no financial benefits that would create a conflict of interest or restrict my independent judgment with regard to the content of this presentation. At any time while viewing the video streaming course, you can take a break by simply pausing your computer. At the completion of this section, you will be asked to take a short exam in order to complete the requirements for streaming video courses. At the time, you will receive instructions regarding taking the exam. This section presents information to create an understanding of the continuum of sedation through which the dentist can make appropriate choices of pharmacologic agents that can be safely and effectively used for various pediatric dental sedation procedures. This course is part of a 16-hour comprehensive program designed to meet the requirements of Texas State Board of Dental Examiners Rule 110.17, Sedation Anesthesia of Pediatric Patients. This is Module 6. It's discussing the pharmacology of sedation and anesthesia agents. Upon completion of this course, you will be able to understand sedation anesthesia pharmacology, determine the most favorable medication and technique to use with a pediatric patient. The American College of Emergency Physicians, ACEP, defines procedural sedation as a technique of administering sedatives or dissociative agents with or without analgesics to induce a state that allows the patient to tolerate unpleasant procedures while maintaining cardiorespiratory function. Procedural sedation and analgesia, PSA, is intended to result in a depressed level of consciousness that allows the patient to maintain oxygenation and airway control independently. The selection of pediatric sedation or anesthesia agents is based upon several factors. The desired outcome is 1. For example, management of the patient's behavior so that treatment may be rendered with minimal risk to the patient and allowing return to the pre-sedation state of consciousness. Completion of some or all of the dental treatment planned for the patient and enabling the patient to feel comfortable with the outcomes of the treatment without following anxiety. The selection of agent to provide the duration of care needed to accomplish the treatment, the limitation of the treatment so that duration doesn't exceed the limitations of optimal drug effect, and little to no memory of the procedure delivered in a safe, effective manner. Various drugs may be used to provide pediatric sedation. A short-acting benzodiazepine, for example midazolam, used either alone or with an opioid such as meperidine or Demerol, a narcotic analgesic, is frequently used to sedate children. When used in combination, the opioid and benzodiazepine increases the risk of oxygen desaturation and cardiorespiratory complications. Specific reversal agents for opiates, naloxone, Narcan, and benzodiazepine, flumazenil, must be readily available during the procedure. An emergent drug, dexmedetomidine, has shown to have minimal hemodynamic effects and a reliable onset of action. More study is needed to ensure it is a safe drug for outpatient procedures. Ketamine is often used in the emergency room for pediatric dental patients and results in a dissociative state. Patients may not be able to speak and respond purposefully to verbal commands. It's not typically used in the pediatric dental outpatient setting. It is often used in emergency room venues, administered by physicians. Though emergent delirium is reputed to not be present in children less than 15 years of age, one must be trained in its use and be able to return the patient to the pre-sedation level of consciousness. For IV in-office pediatric sedation, propofol, fentanyl may be used with a benzodiazepine by anesthesiologists or dental anesthesiologists. Benzos provide amnesia, anticonvulsant, anxiolysis, and sedation, but not analgesia. This drug class works by potentiating the gamma-aminobutyric acid inhibitory action in the CNS by binding to benzo-specific receptors on the GABA benzodiazepine receptor complex within the neurovascular system. Binding of this complex potentiated GABA-mediated chloride influx that results in sedation, amnesia, anxiolysis, and anticonvulsant effects, and respiratory depression. Midazolam is a lipophilic benzo that is fast-acting, creates amnesia, and improves awakening compared to diazepam. Its lipophilic character allows greater distribution, which is amplified in obese patients by a longer half-life up to 8.4 hours. It is cleared by hepatic hydroxylation, and its metabolite has about 10% of the pharmacologic activity of the parent compound. Benzo's diagram here on GABA is showing that the sedative effect can be taken to provide a calming effect, thus having an agonistic effect by imitating the action of GABA, thus inhibiting an overly active physiological response caused by exposure to phobic stimuli. By allowing more negatively charged chloride ions to enter the postsynaptic neuron, it has a similar effect to alcohol. And as you see by the diagram, there are specific receptor sites in the gamma nerve ending, and the drugs that we use, the benzodiazepines, shoot for those sites and reduce the effect of the endogenous secretions. Lorazepam, or Ativan, may be used for mild to moderate sedation, and its onset of action does not peak until 15 to 20 minutes after administration. This drug has nearly double the potency as that of midazolam, and the duration of lorazepam is longer, about 6 to 8 hours, than that of midazolam, which is 30 to 60 minutes. It is generally not used in pediatric dentistry due to this feature, and more so in ICU settings. When benzos are combined with alcohol or opioids, the sedative and respiratory depressant effects are greatly increased, as well as for cardiovascular depression. Opioid pharmacology. Opioid receptors are present within the CNS, central nervous system, as well as the peripheral tissues. These receptors are stimulated by endogenous peptides, endorphins, enkephalins, and dimorphins produced in response to noxious stimulation. The mu agonistic for morphine are found in the brainstem and medial thalamus and are responsible for respiratory depression, euphoria, and sedation. Subtypes MU1, analgesia, euphoria, and serenity, and MU2, respiratory depression, pruritus, prolactin release, dependence, anorexia, and sedation. The inhibition of GABA in the nucleus is intensely pleasurable. Pure opioid agonists stimulate mu receptors, are the most potent analgesics. Naloxone and naltrexone, which is longer duration, have antagonistic effects with fast onset and low bioavailability, resulting in re-narcotization. Therefore, patients who use Narcan is the drug that's given by injection to reverse overdoses, traditionally from heroin. It works because it has much greater affinity for the opioid receptors in the brain than heroin or morphine. Opioids are opioid receptor agonists. It binds to the receptor on the outside of the cell and elicits a pharmacologic response on the inside. By contrast, naloxone is an opioid antagonist that binds to the receptor but does not trigger a pharmacological response. Naloxone acts within minutes and lasts for about an hour because of rapid metabolism. This makes it ideal for opioid overdose rescues. Additionally, the metabolite of naloxone is not an opioid receptor agonist and therefore has a short duration and must be used repetitively to avoid resedation. In the rescue of patients who have been overdosed with opioids, it's important to understand that naloxone given as an antagonist will not last as long as the opioid effect and therefore must have to be repeated to avoid resedation. Non-healthcare provider naloxone administration in the 2015 guidelines of the American Heart Association at an initial dose of 0.4 milligrams IM or 2 milligrams intranasally. Recently, the FDA has approved a newer version of Evzio that delivers 2 milligrams of naloxone IM or sub-Q, 5 times the initial dose administered by the original device. There is no standard dosage for naloxone administered for respiratory distress. However, multiple empiric dosages administered by EMS personnel range from 0.4 to 2 milligrams IM, sub-Q, or intranasally until effect or the effective reduction of respiratory condition. It remains to be seen if Evzio injector will be successful or rescue doses such as AHA 0.1 milligrams per kilogram bolus every 2 minutes to a max dose of 2 milligrams. For example, 20 times 0.01 is 2.0 milligrams for a 2-year-old to 3-year-old, reversal of respiratory reversal dosage. It is apparent from the information from the American Heart Association that the rescue dose of 2 milligrams is thought to be a good initial dose when the patient is experiencing opioid overdose, and that subsequent administration of 2 milligrams up to the dosage of 2 milligrams is an optimal dosage for reversing the effects of opioid intoxication. Therefore, it's important for us to understand a rescue dose may reverse entirely all the effects of the opioid drug. However, it may not be sufficient to rescue the patient that's been overdosed. Naloxone is an opioid receptor antagonist indicated for reversal of opioids due to overdose. Smaller dosages are required for patients with respiratory depression. It's important to distinguish that entire reversal of the opioid dose is different than the smaller dosages used for patients with respiratory depression. For total reversal, for example, all the effects of the opioid is 0.1 milligrams per kilogram IV, intraosseous, IM, and subcutaneous. If total reversal is not required, 1 to 5 micrograms per kilogram IV, intraosseous, intramuscularly, subcutaneously can titrate to response. So if a patient has an IV in place, it will be a simple matter to administer the 1 to 5 micrograms per kilo and reverse the difficulty with respiratory depression without reversing the entire effects of your entire opioids. Total reversal is not required. If you were giving an IV dosage, then you could immediately give the 1 to 5 micrograms per kilogram IV, intraosseous or intramuscularly, subcutaneously to titrate to response and recover from the respiratory depression without reversing the total effect of the opioids. For example, things that might allow the patient to be continued treatment during that time frame with the titration of the partial reversal for the respiratory depression. Continuous IV or IO infusions at 0.002 to 0.016 milligrams per kilogram per hour, 2 to 160 micrograms per kilo per hour. As those are continuous dosages if we are trying to reverse, let's say, the respiratory depression and to minimize the amount of reversal agent to our patient for the behavioral control. Again, this has to be decided and thought through well in advance in a rescue situation. Opioids are metabolized in the liver and excreted by the kidneys. Fentanyl is a strong opioid and about 80 times more potent than morphine, highly lipophilic and binds strongly to plasma proteins. It undergoes metabolism in the liver, and drug clearance may take up to 24 hours. This drug is often used by anesthesiologists for outpatient IV sedation in dental offices. This is not a drug that is meant to be used by the untrained practitioner because it's very strong opioid, and it's 80 times more potent than morphine, and therefore highly lipophilic, which means it's widespread throughout the body and binds strongly to plasma proteins. Therefore, fentanyl is a good drug to be utilized IV by trained clinicians. Meperidine is 10% of the effectiveness of morphine. The half-life is 3 hours and metabolized to normeperidine with the significant neurotoxic properties and an effective half-life of 15 to 30 hours. This means that once the metabolite of meperidine is accomplished, there's still a half-life of 3 hours for the normeperidine, which has neurotoxic properties and also an effective half-life of 15 to 30 hours. So it doesn't go away with the simple metabolic processes, but will hang around for up to 30 hours. The metabolite extends the physiologic opioid effect. It is not to be given to patients being treated with monoamine oxidase inhibitors, and if so, produces severe respiratory depression. Meperidine metabolites account for over half the drug in the urine. Normeperidine is devoid of analgesic activity, but it is a potent stimulant of the central nervous system. Its main adverse effect is neurotoxicity, producing symptoms that include nervousness, tremors, muscle twitches, and seizures. Opioids provide analgesia and sedation for painful procedures. Meperidine is not a good first-line agent due to active metabolites that can have neuroexcitatory effects and accumulate in those with poor renal clearance. In pediatrics, the latter is generally not an issue, but the potentiation of seizures is due to lowering the threshold and increasing mast cell release in allergic patients. Therefore, meperidine is not a drug to be given to patients who are prone to seizures and mast cell release. Fentanyl is favored in IV sedation because of its prompt onset and short duration of action. It's titrated by anesthesiologists for pediatric procedures and has little cardiovascular depressive effects, and hypotension rarely occurs. It binds with the stereospecific receptors at many sites within the CNS and increases pain threshold, alters pain reception, and inhibits ascending pain pathways. This is a drug that's often used in the emergency room and provided by anesthesiologists or trained physicians. The intranasal dosage is 1.5 to 2 micrograms per kilo, and IV dosage is 0.5 to 3 micrograms per kilo. Side effects include rigid chest syndrome, and this is a spasm of the respiratory muscles leading to insufficient respiration and inability to ventilate the patient through artificial means. To reverse, neuromuscular blockade must be introduced to paralyze the chest wall muscles and allow for effective respirations. Naloxone has been reported successful in reversing this syndrome. This is one of the reasons why it's generally handled by MD anesthesiologists, because they are trained to handle the rigid chest syndrome, and this would keep us out of trouble by having an expert deliver this in our offices. Propofol is primarily used for short-term sedation in pediatric patients. Propofol's adverse effects on the respiratory and cardiovascular system are significant. Propofol may induce apnea, but likely not respiratory depression. It is less likely to incite bronchospasm than barbiturates. Cardiovascular effects of propofol include hypotension and decreased cardiac output from a decrease of systemic vascular resistance and cardiac contractility. So this latter effect, cardiovascular effects of propofol, decreases blood pressure and decreased cardiac output, a terrible combination from a decrease in systemic vascular resistance and cardiac contractility. Propofol is 10% oil in water emulsion containing a lipid component composed of egg lecithin and soybean oil that should be avoided in patients with egg and soybean allergies. Ketamine and mu opioid receptor agonism contributes to ketamine's analgesic property. Ketamine's dissociative and analgesic effects can begin at sub-anesthetic doses, whereas its psychotogenic reactions increase in severity with higher serum concentrations achieved by anesthetic dosages. This is a drug that's used in the operating area of emergency rooms, that's administered by MD physicians, and they feel comfortable with the dissociative effects. And as was mentioned before, in children that are younger than 15 years of age, these dissociative effects does not appear to be an active result of this drug's usage. Ketamine's dissociative and analgesic effects can begin at subanesthetic doses, whereas its psychogenic effects increase in severity with higher serum concentrations achieved by anesthetic dosages. So the dosage amount produces its psychotogenic reactions, increase in severity with higher serum concentrations achieved by anesthetic dosage. Ketamine preserves the laryngeal reflexes and allows spontaneous respirations, making it favorable for procedural sedation. In addition, ketamine is a potent bronchodilator. Bronchodilation is thought to be the result of catecholamine release, inhibition of vagal tone, and direct smooth muscle relaxation. Intranasal administration of sedative drugs before performing the dental incision has taken hold because it is a practical and non-invasive route of administration. Ketamine levels of sedations can be reached via intranasal administration due to the rich vascular plexus cavity which communicates with the subarachnoid space via the olfactory nerve. This is a mucosal atomizer device, and this mucosal atomizer device has a soft foam tip that can be placed in the nares, and the dosage of medication that's used can be divided in half, so one for each side. The utilization of midazolam, for example, is a drug that can be administered with this mucosal atomizer device or MAD device, and when it is used, the dosage can be applied half to each nares. In the rescue situation where naloxone needs to be administered, it's important this can be used and also applied intranasally by putting 1 milligram in each nares, and that can be the continued method of drug delivery. However, it does cause some nasal irritation and a little bit of stinging, and I believe that the patients having this sort of dosage as a rescue drug would not mind this as much as a sedative drugs that we try to use this for. Drugs used for intranasal administration. Ketamine is used at the dosage level of 5 to 9 milligrams per kilogram. Ketamine is used with midazolam. Remember that ketamine is the dissociative drugs and midazolam is the benzo. Ketamine with sufentanil. Again, this is a combination that can be utilized for dissociative effect, and the sufentanil has some of the same characteristics as fentanyl in that it has very little effect on the cardiovascular and respiratory system. So ketamine will have the dissociative effect, and the small amounts of sufentanil used for controlling analgesia and sedation. Midazolam was used by Rakoff et al. In 2011, 91 to 100% effective dosage at 0.2 milligrams per kilogram and 0.4 milligrams per kilogram or 0.5 milligrams per kilogram. The side effects indicated were burning or irritation in the nose and bitter taste in the mouth. Sufentanil onset was 5 to 10 minutes. Maximum sedative and analgesic effect in about 20 to 25 minutes. The pain dosage 0.7 to 1.0 micrograms per kilo. Effects marked decreased ventilatory compliance and vomiting the first post-op day. The fentanyl intranasal dose, 1.5 micrograms per kilogram, used with the mucosal atomizer device for painful procedures. Dexmedetomidine dose, 2 to 4 micrograms per kilo intranasally, has a side effect of symptomatic bradycardia precipitating vasovagal syncope. So this drug still has to be investigated to see if it's useful in the utilization of dental sedation. Advantages of the intranasal administration. The advantages of atomized delivery include less drug being lost to the oral pharynx, higher cerebrospinal fluid drug levels, better patient acceptability, and improved sedative effects. The disadvantages is the burning or mucosal irritation sensation in the nares. In addition to analgesia, opioid agonists suppress the cough reflex and cause respiratory depression, drowsiness, and sedation. The half-life is 2 to 4 hours. Meperidine lowers the threshold for seizure activity and should be avoided with patients that have a history of seizures. Meperidine has been in use in combination with hydroxyzine that reduces the release of histamines in patients with allergic histories. Remembering that hydroxyzine is an antihistamine. It reduces activity in the central nervous system, acts as a sedative to treat anxiety and tension. It acts as an antihistamine that reduces the effects of natural chemical histamine in the body. Hydroxyzine is an antihistamine often used with meperidine to offset the histaminic action of that drug. Its dosage for pediatrics is 0.6 milligrams per kilo. Its side effect is dry mouth, headaches, and constipation. It's metabolized in the liver and excreted in the kidney. Hydroxyzine can be used as a sole sedative medication. It's very mild in its effect, and its dosage is relatively low, but it does cause dry mouth, headaches, and constipation. Hydroxyzine, as Atarax hydroxyzine hydrochloride or Vistarel hydroxyzine pamamate, are antihistamines with anticholinergic drying and sedative properties to treat anxiety and tension. Combined with other drugs such as meperidine for anesthesia, control of nausea and vomiting, or to treat allergic skin reactions. Its side effects are dizziness, tongue irritation, drowsiness, blurred vision, dry mouth, stomach upset, headache, restless muscle movements in your eyes, drowsiness, as mentioned in the jaw and neck, tremors, confusion, and constipation. Tremors may include uncontrolled shaking. The onset of effect by hydroxyzine occurs between 15 and 60 minutes, with a usual duration of action of 4 to 6 hours. The recommended dose is 0.6 milligrams per kilogram. Hydroxyzine produces clinical actions within 30 to 60 minutes, with a maximal clinical duration of effective sedation between 1 and 2 hours. The sedative actions of hydroxyzine are not produced by cortical depression. It is thought to suppress some hypothalamic nuclei and to extend its actions peripherally into the sympathetic portion of the autonomic nervous system. In dental practice, the use of hydroxyzine as a sole drug is limited to the management of children with mild to moderate fear. It is often used in combination with meperidine for management of more fearful pediatric patients. Hydroxyzine will potentiate CNS depressant actions of drugs such as barbiturates, opioids, alcohol, sedative hypnotics, and anti-anxiety drugs. Dosages of these drugs should be decreased by 50% when they are administered concurrently with hydroxyzine. My experience has been I used for 20 years hydroxyzine as a co-medication with meperidine. We used 500 milligrams of Demerol and 25 milligrams of hydroxyzine. It was an excellent drug combination. We used it for years, and unfortunately the chlorohydrate with which it was used at a 500 milligram dosage is no longer on the market, but hydroxyzine and meperidine are still available for sedating patients. In the meta-analysis study by Slick et al. In 2015, the accumulated 50 cases studied, 20 were deemed likely to be seizures, 26 indeterminate, and 4 unlikely. The outcomes suggests that despite seizure being a potential adverse effect, it may not be common. Pediatric cases of sickle cell, the incidence was 0.4% itself, has been shown to predispose to seizure activity. Therefore, this meperidine and seizures does not seem to be related as much to seizure development as was previously thought. This study used intradermal microdialysis to measure the dose-dependent release of histamine and tryptase on the opioid receptors. Of the synthetic opioid tested, only codeine and meperidine induced mast cell activation and release of tryptase and histamine, causing protein extravasation, flare reactions, and itch reactions. Therefore, this has shown that meperidine is often combined with antihistamine hydroxyzine to counter the inducement of mast cell release. Hydroxyzine presents in two forms: hydroxyzine pamoate and hydrochloride. In a study by Zygmunt in 1989 in 65 healthy human volunteers, the addition of hydroxyzine, 1.5 milligrams per kilo, to meperidine, 1.5 milligrams per kilo IV, caused a significant reduction in the partial pressure of oxygen only at 10 minutes, but a greater increase in pA of carbon dioxide and or pH at all times for 60 minutes than did meperidine alone. However, PaO2 and PaCO2 and pH remained within the awake normal ranges for PaCO2 and PaO2 and pH for the age group, even at 10 minutes after IV injection of the drug combination. The point of this study was to show that hydroxyzine and meperidine can be used in combination and are much more effective than just meperidine alone. Need clarification, and an email sent to the PACE Center at uth.tmc.edu with questions. We will help you identify. If you use these references, you can substantiate this information for yourselves and use this as a learning tool to guide you through the information that was used to prepare this presentation. So it's available to you, but if you have any questions, please give us a call. This completes this section of the course. It's time for you to take a short exam in order to complete the requirements for streaming video courses. Due to the nature of our subject content, a passing score of 80% is necessary in order for you to advance to the next section. Upon a successful completion of this exam, you will be visually informed that you have met the requirements to proceed. If you fail to answer enough questions correctly, you will be instructed to take the exam and a new set of questions will be provided. You will have 3 chances to fulfill the requirements. If you are not successful, you will be instructed to review this section again. Good luck on the exam. If you're ready to take the next section, upon the completion of this exam, you will be provided a link to continue. If you wish to proceed at a later date, you will need to log in and no further payment is necessary since this is the continuum.